teaching obligation of the director, the rotation director of neuro-ophthalmology, been involved in many local, regional committees, as well as presented nationally. A pleasure to introduce me here today. It's my honor to be here today at the presentation. So hopefully you guys will enjoy discussing over the next hour a topic that I find challenging. So, to disclose. And to start off, I want to start a little differently. Just a few kind of self-test questions. You don't have to share your answers for these, but if you want to just think to yourself how you might answer these currently. Hopefully you actually don't know the answers to most of these questions, because that would make this talk for us. But there are visit these at 9:10.
That's all right. Just
So first, what percentage of patients undergoing brain MRI would be expected to have at least one radiographic sign of for two, what percentage of patients undergoing brain MRI would be expected to have at least moderate, partially empty sella? For three, what percentage of patients undergoing brain MRI would be expected to have papilledema on this exam? Number four, true or false, pituitary hormone abnormalities are common in the setting of incidental discovery of sella. Finally, what is the most common form of infected? So again, just keep your ideas to yourself, and hopefully we'll see some growth by the end of this talk. So it gives you a little bit of insight into some of the things we're going to be talking about today. But as many of you know, empty sella is a common finding on cranial imaging. It's also been associated, though, with conditions of elevated cranial pressure, particularly with pseudotumor. In addition to empty sella, there are other radiographic signs of potentially increased ICP, which we'll also discuss. And when these signs are incidentally found on MRI, it often leads the radiologist to advise the clinician to consider pseudotumor cerebri, idiopathic intracranial hypertension. And that can actually a lot of times result in potentially unnecessary insert testing. So there's also often confusion among clinicians about whether the discovery of an empty sella has any implications for status. And thus we'll also discuss a logical, evidence-based approach to what to do with these patients that we come across with empty sella, MRI signs and ICP. So the term empty sella refers to a neuroimaging finding in which the sella turcica, which is the skull-based structure which houses the pituitary gland, is either partially or fully filled with CSF. And empty sella was first described in 1951 as a peculiar anatomical tradition in a cadaver. So to get a sense for what empty sella looks like, let's first look at some examples of what a full sella region should look like. So here's a midline sagittal MRI image demonstrating an example of the appearance of a normally configured sella region. So it went from normal flat contour to the upper margin of the pituitary tissue within the subspace. Here's another example. Pituitary sella. In this example, we see slightly convex contour to the superior margin of the pituitary. In children and adults with the superior border of the pituitary gland is usually convex flat. So here's an example of an empty sella. In this image, we see a significantly concave appearance to the upper margin of the pituitary, which appears as just a thin white strip at the bottom of the sella. The remainder of the sella is CSF. And so contrast that with the that significant concavity with the prior two examples. See there's a big difference between a normal appearance and an empty appearance there. So here's another example of an empty cella, although in this case we also have a pretty significant expansion of the cella. And here's an example of what would be termed a partial empty cella. In this example, we see a mild concavity to the superior margin of the pituitary. So empty cella is divided into two types: primary empty cella, which is occurrence of an empty cella without any known abnormality of the pituitary gland, and secondary empty cella, which occurs as a result of pituitary pathology. So primary empty cella occurs due to the herniation, accumulation of excess CSF within the cellular space, which winds up compressing, flattening the pituitary gland. This increase in CSF can be attributed to increased intracranial pressure and incompetent cellular diaphragm, physiologic pituitary pollution, or a combination of those factors. Secondary empty cella arises from any pituitary pathology, which causes the gland to shrink relative to the cellular space. So most common etiology is iatrogenic as a result of medical surgical radiation, treatment of pituitary tumors, but other pituitary conditions such as trauma, infection, infarction. So it's important to know that primary empty cella is quite common in the general population, with prevalence estimated between 8 and 35%. It's also important to note that empty cella is more common in women and more common with age, as it's been shown that that pituitary height declines with increasing age in both males and females between the age of 20 and 65. This decline is highly significant in females. This age-related decline in pituitary gland size likely reflects at least in part the neuro-ophthalmology of aging and physiological pituitary atrophy. Another important definition to keep in mind is empty cella syndrome, which is the situation where a primary empty cella is not just an incidental finding, but associated with neurologic, ophthalmologic, or endocrinologic deficits. So in addition to being a common finding in the general population, empty cella or partially empty cella has also been shown to be associated with increased intracranial pressure. Currently, the only definitive ways to measure intracranial pressure are invasive, such as lumbar puncture or intracranial bolt. As such, there's been significant interest over the years in potentially using MRI signs, such as empty cella, to be able to non-invasively diagnose ICP. That interest has been particularly intense. So pseudotumor cerebri syndrome is characterized by increased intracranial pressure resulting in papilledema with normal spinal fluid composition as determined by lumbar puncture in the setting of normal brain parenchyma without hydrocephalus or mass lesion. It's a relatively common condition, primarily affecting young obese women. And in turn, pseudotumor cerebri syndrome encompasses both primary intracranial hypertension of unclear etiology, also known as idiopathic intracranial hypertension, or IIH, as well as secondary causes of increased ICP that include normal brain imaging, CSL. So the terms pseudotumor cerebri and IIH, terms which have been fairly commonly changed by many clinicians, although they're not exactly changeable. But because of this common practice, you'll see through many of the studies that we talked about today, some of them to it is IIH, some pseudotumor, so by using these terms, changing a little bit. So empty cella has been associated with elevated ICP and pseudotumor cerebri for many years. However, this study in 2000 was one of the first to actually investigate the morphologic changes of the pituitary gland with IIH. So in this study, analyses of pituitary morphology retrospectively in patients with IIH, normal patients, and patients with acutely elevated ICP secondary to trauma. The elevated ICP of those patients was confirmed by intracranial pressure. So a loss of pituitary height, which is akin to the concavity of the superior margin pituitary gland that we looked at on the examples at the beginning of this talk. That was assessed on sagittal T1 images from patients and classified into 5 categories, with category 1 being normal. Category 2 is less than 1/3 decline of pituitary height. Category 3 is 1/3.
No one's in here. No, everyone beelined it in there like late, so no one's signed in yet. So I have to catch everyone when they come out to sign in.
Using category 3
yeah.
or moderate cavity as minimum criteria, the incidence of at least firstly, empty cella was 85% patients with IIH, 13.5% in the acute head trauma patients, 4% is fine sensitivity, 80% on specificity. We sell category 5 was seen in just 2.5% of the IIH patients, which was much lower than some of the other prior studies, which ranged at 5 to 3%. This may have to do with the fact that in this particular study, they were very specific about dermatology treatment with So in addition to empty cella, several other MRI signs have been associated with increased ICP, including flattening of the posterior sclera, enhancement of optic extension of the perioptic sheath, the tortuosity of the optic, and intraocular protrusion of prelaminar optic. So let's take a look at some of these. Here's an example of a patient with pseudotumor cerebri that has flattening of the posterior lobes. Also has sella. Here's another example of flattening the posterior lobes for a different patient. This patient actually had venous sinus tuberculosis. It's a different patient with pseudotumor with you can see on these images dilated optic sheets. This is a different patient. We can see dilation of optic sheets at the left, also right, and we can also see some protrusion of that left optic. In this retrospective case control study by Brodsky in 1998, which looked at 20 patients with pseudotumor and 20 controls, all study findings were quite common in pseudotumor patients that had different controls. All findings were statistically significant except we can see that flattening of the posterior sclera. Another finding reported to be appreciable in more than 90% of patients with pseudotumor is narrowing of the transverse or sigmoid sinuses on testing. This study by Barb and colleagues demonstrated this finding to be 93% sensitive and 93% specific. Here we have an MR venogram image from a patient with dominant right transverse sinus and left transverse sinus of loose stenotic, and it's likely genetically hypoplastic, but we also see the dominant right side of the transverse sigmoid junction. And this is from the same patient. As I mentioned earlier, the presence of papilledema is a required diagnostic element in the diagnosis of pseudotumor. However, there's a much rarer form of pseudotumor, which has come to be recognized, where we have all the diagnostic elements. However, the patient does not have papilledema. This is referred to as pseudotumor without papilledema. In 2013, revised diagnostic criteria for pseudotumor published to include criteria for the diagnosis of papilledema. So one of the ways that diagnosis can be suggested is if the patient has a 6-nerve palsy, in addition to all the other required diagnostic elements. However, in the absence of 6-nerve palsy, the diagnosis of IH without papilledema can be suggested. All the typical criteria are there, and at least 3 of 4 imaging findings are present, including empty sella, flattening of the posterior aspect of the lobe, increased perioptics, CSF space, or transverse sinus stenosis. With the revised diagnostic criteria for pseudotumor, incorporating imaging findings into the diagnosis of pseudotumor without papilledema, the study in 2019 was undertaken to evaluate the sensitivity and specificity of these findings and to validate the utility of diagnosing IIH in patients without papilledema, but with chronic headaches and elevated blood pressure. The study looked at 3 groups of patients. Typical IIH patients with deferred papilledema, which include 80 patients, chronic headache with elevated ICP but no papilledema patients, which included 33 patients, and patients with infrequent migraine used as controls. That consisted of 70 patients. The presence or absence of papilledema. MRIs were reviewed by a neuroradiologist at each participating center using a defined protocol to ensure consistency in interpretations, and neuroradiologists were asked as to the clinical status of the patient by bias. And each of the 4 MRI features were evaluated separately so that the presence of MRI finding And pituitary gland height was significantly reduced in the IIH with papilledema groups of 80% of patients, and the chronic headache developed CSF pressure groups at 82%, compared to was only seen 6%. Similarly, the mean optic nerve sheath significantly increased in the IIH with papilledema group seen 51%, and chronic headache with elevated CSF pressure group seen 42%, compared with controls were expected. So reduced pituitary gland height is moderately sensitive at 80%, identifying IIH with papilledema that had low specificity at 64%. Increased optic nerve sheath diameter had a sensitivity of 51%, only moderate specificity at 80%. Lacking the posterior lobe was highly specific at 97%, but had low sensitivity, identifying IIH. And transverse venous sinus stenosis was moderately sensitive for IIH with papilledema. Specificity was undetermined because they So this graph here shows the breakdown of the number of patients in each group with either 0, 1, 2, 3, or 4 MRI features of intracranial hypertension. And in the control group, 50% of patients had one MRI feature present. 2 features were present in that group, and only 2.9%. While in the IIH with papilledema group, multiple MRI features were common, with 85% having 2 features and 48% having 3 or more features. The chronic headache with elevated opening pressure group, 55% had 2 or more MRI features, and 30% had 3 or more. And a combination of any 3 of the 4 MRI features was nearly 100% specific for IIH with papilledema, while maintaining sensitivity of 64%. At least 3 of 4 MRI features were identified in 30% of all patients with chronic headache with elevated CSF pressure without papilledema, and 36% of these patients with. So the results show that MRI features of intracranial hypertension may detect a subset of patients with IIH without papilledema among those patients with chronic headache with elevated ICP, which amounted to 30% of the patients of that cohort within this study. The results of the study validate that the presence of 3 of 4 MRI features of increased intracranial pressure are suggestive of IIH without papilledema when present in patients with chronic headache who have no papilledema and elevated LV pressure. And another important takeaway, which is not a main focus of the study, but an interesting result, is that it highlighted that having one sign of intracranial hypertension is very common in patients, 50% in the study, and first empty cell being seen 6%. So with much of the focus in recent years being on using MRI signs of high ICP to aid in the diagnosis of pseudotumor and the diagnostic criteria of pseudotumor without papilledema, even adopting some of these radiographic signs, it's important to keep in mind that these MRI signs are not specific to pseudotumor. It can be seen with any cause of elevated ICP. So here's a study highlighting this fact. This was a 2011 study that assessed various MRI signs of increased ICP in patients with secondary intracranial hypertension. So in other words, specifically in patients who had an increased ICP from identifiable causes. So essentially excluding patients with idiopathic intracranial. So this was a prospective study that had 36 patients, including 7 kids, secondary increased ICP, various causes. Some of the causes include things like meningitis, venous sinus thrombosis, interjugular vein occlusion, and brain tumors. Control group were age and sex matched patients who had gone MRI for other indications, mostly psychiatric concerns, without any clinical evidence for increased ICP, such as headache. And special attention was paid to a variety of MRI findings as listed there, and various venous parameters were also assessed, including severe ophthalmic vein diameter and venous sinus stenosis. Study showed that all of the investigated findings were statistically significantly different between patients and controls. Most common findings were cranial venous outflow obstruction, optic nerve sheath dilation, empty sella, flattening of the posterior sclera. The researchers found that venous outflow obstruction, optic nerve sheath dilation, reduction of pituitary height discriminated less between one and more than that. Most other signs showed a high specificity but low sensitivity. The study demonstrated well that cranial venous outflow obstruction is not a specific feature of patients with pseudotumor, but is a universal phenomenon most patients with intracranial hypertension, irrespective. So it's important to remember that these findings are suggestive of potentially elevated ICP, not specifically suited to pseudogram. Here's a good example of some of these various findings in a patient who has an obvious secondary cause for increased ICP. Here we have highlighted a 21 millimeter by 18 millimeter mass lesion at the right cerebellum-pontine angle, which is resulting in mass effect on the brainstem ventricle. With this large mass, we can see multiple signs of increased intracranial pressure, including partially empty sella. We see protrusion of the right optic disc into the lobe and bilateral.
There's a few more people in there. Right? It's last week was small too, right?
Like the second, I mean, that's kind of how it is. I don't know if she. Messaged it right at 4. Yeah, there was definitely like. Maybe like 4 more people that came in after she messaged it anyways, but it's lately. Lately, DMT hasn't really been attending.
We're gonna figure out that.
Okay.
But maybe that's.
Yeah, lately they haven't been attending.
Sarah was there back.
And boss has been taking it virtually lately. I know. But then he goes on his phone. Yeah. And then
Tuesday back.
was she not in there?
She's.
Oh, yeah. You know what I'm saying? Like they kind of just like I understand, like it's kind of like you were here for a day.
Yeah.
Or it's like
Maybe we got for rebasketball like. This time sheets. Like. Physical attention, physical, in-person attendances.
part of me's like, is 4 o'clock too late?
But I feel like that's the time that works ideally for. It's easy to close clinic just an hour early.
Yeah, because lately it's been a lot less.
Yeah.
What was it then, dude?
I know.
Well, or does it need to be us looking again at, because isn't Stephanie's clinic closed for grand rounds?
Don't know.
I think so. So I think, or do we need to start looking again at, we have clinic closed for people for grand rounds?
Right, that's why.
And they're not.
All of those went. I feel like all. That kind of pass.
Did it get switched again?
Yeah. Like where we. Blocked.
Oh. Those got removed.
I think one is. Don't quote me.
Step, so do you think that then you
Please bring it up.
very bad, you're bad or so? Oh.
It's because he's asking the question. He's not at a speaker. It's that girl.
Yeah, so I would say.
Um,
Probably,
so do we not have, so like
because
Travis
people
Collar
have,
doesn't have grand rounds blocked anymore?
have subtle
I'll have to.
swelling in the abdomen.
We
That
should
is
still.
Alabama, like Stephanie doesn't have it blocked anymore.
There's times where on this exam.
Survey doesn't have it blocked anymore.
And something about it, we get.
Kating.
And then there.
Yeah.
So
I'll
it has
check
to be-
tomorrow before I'm-
Okay.
I would say it has to be. It does not have to be.
But I feel like that's also like one of those things where it comes in to play too on a question of like department or like division, like
Your optometrist.
like what's the word? Like what's the word I'm looking for? Like division, like or like support or like like I get you're online, but it's like
Nowadays, technology. Just like they did a study, they obtained.
Yeah, it's like- that's kind of like, hold on, do we just do it online?
Wait, I'm thinking about
So
it.
that.
Or do we just do it online when it's an MCW person?
They've been sort of the whole trying to figure out ways to get buying things in all these clinics that need it without having to have the idea. So, for example, they've been instrumental in getting this non-pancreatic
Right.
into ERs, neurology clinics, and things like that. Because if you had that available to you and you had some time to look at that thing, if you had that, I would say first said we've got a non-pancreatic one this photography machine. I've got
She'd probably push it. It would be just in person.
Something.
But we have a lot of people that I mean, not a lot, but sometimes we get a lot, depending on the topic.
Yes, I do. But that was very nice, Ryan. Thank you for that excellent presentation.
Dr. Fitling.
A question about you, maybe I missed this, I got a little late. What about body weight? I mean, it seems like, these subjects tend to have obviously. So. My question is.
Yeah, I'm just curious. Yeah, I didn't know that we were.
More concerned when we see these others not obese or. Does that matter? Body weight, okay.
Oh, really?
So.
So like case conference too?
The vast majority of patients we see are obese in adults. Kids.
Oh, are they using it?
Condition. So in children, it has nothing to do with obesity.
Okay.
Always girls.
Okay. Okay.
Once patients kind of post all I would say is when they start following the pattern that we see in adults, and in adults is the vast majority of patients are young obese women. It's also not unusual that they've recently gained weight. So they may not be super morbidly obese, but maybe they gained 30 pounds in 6 months. That's often true. Interestingly, it also appears that increased prevalence of empty sella associated with obesity, even without pseudotumor. So when they just look at primary empty sella patients that don't have a diagnosis of pseudotumor, there seem to be just primary empty in terms of what to do with an empty sella, I don't look at whether they're obese, not obese. If the image comes back and you can see that the patient has an empty sella, or it's LP, you should be getting an LP on this patient if they have an empty sella. You don't need to get an LP, but you should have somebody look at them with eyes to make sure they move. Thank you. given a slightly different version of this talk to the radiology. And I think they were going to see how common it's fine as well. I think a lot of people, there's been some good research in literature about using these surrogates things. There's a lot of feeling that, oh, if I see these, they've got super. Yeah, I don't know if there's a way for them to report those kind of stuff. One of the interesting things to be in my discussion with the neuroradiologist, well, at least one of the neuroradiologists told me that he actually specifically does not report partially of the sella unless he sees multiple other signs of increased intracranial blood pressure, because of the fact you see that 50% of people that get it scan and have at least one sella based studies that he actually does. I don't know if that's good facts. We're seeing that a lot of these patients are having potentially have deficiencies. A small percentage with some of these patients will have. So I don't know if that's good or bad, but that's been his practice. So he kind of doesn't say it's just a cell. It's the same percent. So yeah, I don't know if there's a way to have sort of the same way that they partition things off, if not midline, supposed to cross and structures. Something that
It's shocking that some because it ends up, about 15% of people have hormone deficiency, right? That one, yeah. So that's interesting.
Yeah. Well, I think I think that should also flavor how you look at some of these studies that are studying. So these retrospective registry studies that are looking at largely every cell. So that one study that I showed, that was a 10-year look back at patients. They had like close to 80 patients, which I actually think that's a pretty minimal amount of patients looking at 10 years. But when you look at the methods, they searched the database for essentially patients whose reports came back saying that they had empty sella. And so knowing that that's the last incorporated. On the other studies I showed you, they actually they looked at all. I don't know if I talked about it today, but there was a study that was done that was looking basically at all comers from a neuro-ophthalmology at Horizon, everybody. They've already had on this time, so they know what percentage of patients have chemo. And so in that study, it was very similar. They had 49% of patients had at least one sign of in that, and they had it was I think in the 40s sella, but they also went back and looked at what percentage of patients actually radiology reports had said the sella, and it was 15%. So they had 40% of patients had empty sella, and it was 15% was even commented. So if you're seeing it in your report, that's even a small percentage. I think what is actually about. So yeah, I don't know how to change that for. I think because I think that's something that has to be looked at if we're going to be looking at big groups of patients to find out what the hormonal abnormalities are in those patients. So I think there's lots of work to be done there to try to fine tune. Because right now our range is 9 to 60% of patients. You want to probably fine tune that with study, but I think it would have to be something where it's tedious. They'd have to actually look at the image to see. Yeah, so the 50%, that's for at least one sign of increased intracranial pressure. The studies that were done well, that were looking at least moderate partially empty cella, that I included One of those studies was 33% and one was 36%. And that was at least category 3. So they weren't including the category 2 patients. That was at least category 3 or beyond, was 33 to 36. Now, those were patients that were getting MRIs. So it's not that they went to the mall and rounded up a bunch of normal people that have no complaints whatsoever. All of these patients had some reason to get a brain MRI because they were taking consecutive patients. But that's the population we deal with, are the patients we're getting MRIs, right? So we can assume that 33% of the MRIs we're getting back, we can expect to see at least moderate partially. I think it's a point.
I had a patient yesterday actually on the floor, so that's about unchanged. Nobody told me that I'd be fine. I'll be fine. She's that they had a treat fish to provide. I was my last thing. Same thing. Yeah, it's interesting. Finding patients.
Yeah.
Because the evaluation, like next step is policy exam, have the things out that, so like, just watching.
Yeah, yeah, so these are patients, so that goes back to, unfortunately, there's no correlation between the prevalence of hormone deficiency or the severity of hormone deficiency with the severity of with your pathology. So this includes not just category 5 and empty cell. This is patients with partially empty cell, and that's why we have such a large percentage of population. And that's also why I think some of the older studies that have way lower percentages they're all done differently. Some of them are autopsy studies, some of them are CT studies, some of them are MRI studies, and then they all different when they're into, they're just talking about complete partial cell, and that's going to be above the percentage. Yeah, no, these recommendations we talk about this.
I love that.
Oh, thank you.